Aortic stenosis essentially is a disease of elderly population. Shortness of breath, chest pain, and syncopal episodes, fainting, these are the common symptoms of aortic stenosis.
So those patients who are at a high surgical risk, there we treat them by TAVI procedure.
Foolproof way of diagnosing aortic stenosis besides the clinical examination is echocardiogram.
There are two types of valves that are available. There's what we call as a balloon expandable valve, and there's another approach which is known as a self-expandable.
We are doing these kind of surgeries for the last 20 years.
Indian patients are different from the Western population.
Lot of people will require valve implantation in future.
This is called a lifetime management of aortic stenosis patients.
So if you see, aortic stenosis is more commonly than not, it's an aging population disease where the patients who are getting older, they'll have breathlessness, they would have effort intolerance, some chest discomfort, and in late stage they would have sudden syncopal attack, and sometimes the first presentation can be sudden cardiac arrest as well. And it's an insidious process, so they might feel that probably it is all part of the aging, but every person should get checked. Their echocardiography is a very simple method whereby we can check it, and this is something which anyone who is getting unusual breathlessness, swelling in the leg and all should get it evaluated.
Aortic stenosis essentially is a disease of elderly population. When we call it calcific aortic stenosis. Sometimes in developing countries, especially, we see rheumatic heart disease and rheumatic aortic stenosis. But when we talk about aortic stenosis, essentially we mean about calcific aortic stenosis, and it presents with symptoms of mainly shortness of breath on exertion. The patient will not be able to keep pace with his peer groups. He will feel fatigued while walking around 100 meters, 200, 300 meters, and gradually it will be getting more and more problem will happen to patients. Besides this, the patient can complain of angina, chest pain, especially on exertion, and then a few times the patient can present with syncopal episodes. Patients are fainting, and then coming to you. Since this patient has a very high LVEDP, any small arrhythmia like atrial fibrillation, they can decompensate and they can have syncopal episodes. So shortness of breath, chest pain, and syncopal episodes, fainting, these are the common symptoms of aortic stenosis.
Right. Now, aortic stenosis and rheumatic heart disease are two diseases which affect the valve in many of our patients. Aortic stenosis is one of the major valves in the heart which drives the blood out from the left ventricle or the main pumping chamber of the heart into the rest of the body. And over a period of time, because of an aging process, because of high blood pressure, this valve tends to become damaged and degenerated, in the sense that the opening of the valve becomes much smaller and the orifice or the valve opening becomes much lesser than what it should be. As a result of this, since the main pumping chamber, that is the left ventricle, is not able to pump blood out of the heart into the rest of the body, patients do get symptoms such as shortness of breath. They can feel giddy, and many times they may end up having a chest discomfort on exertion also. Now, these symptoms initially are only when the patient exerts himself or herself, but over a period of time, as the valve becomes narrower and narrower, the symptoms may extend to even when the patient is sitting or even at activities of minimal exertion, which is even going for a bath or taking care of patient's own day-to-day activities. So that's the time that patient really sometimes seeks attention, when many times the patient should seek attention much earlier when the symptoms are more even on exertion. So this, as I said, is related to an aging process or because of a degenerative process, as we say.
Aortic stenosis is something which can be very easily diagnosed by putting a stethoscope on the patient's chest. So that's a very, very basic examination. Even a simple MBBS doctor or third-year student can find out harsh ejection systolic murmur. However, for the severity assessment, we need further tests, like we can do an ECG recording, and then more importantly, a very good echo. Echo will look at the gradient, and based on echo, we classify them mild aortic stenosis, moderate, and severe aortic stenosis. On more advanced evaluation, we can do a transesophageal echo if the echo window is not good, and then of course the CT or MR can be done to assess it further.
Foolproof way of diagnosing aortic stenosis besides the clinical examination is echocardiogram. So the color Doppler and echocardiography clinches diagnosis in almost all patients. Barring a few situations like paradoxical aortic stenosis, the echo gives us a clear idea about the morphology of the aortic valve, whether it's a tricuspid, bicuspid, how much calcium is there, and how much flow impedance is there, what we call gradient across aortic valve. Essentially, ECG, echocardiogram backed with good physical examination gives you diagnosis in almost majority of the patients.
The most clinically important diagnostic test that we do in patients with aortic stenosis is an echocardiography or an ultrasound of the heart, and this helps us to identify two things. It gives us an idea about the heart pumping or the ejection fraction of the heart, as well as the fact the area of obstruction or how narrow the valve has become. So this is an initial test that we do which will help us to diagnose aortic stenosis. Besides the echocardiography, we also do basic tests such as an ECG, which will tell us whether there is any electrical disturbance in the patients as a result of aortic valve affection. We also do get an X-ray chest done, which tells us some degree about calcification or stiffness of the aortic valve. And then this is followed by something that is done in more advanced patients, which is known as a CT coronary angiography or an aortogram or a CT aortogram, which helps us to identify the exact annulus or the size of the valve that is affected. It tells us about the degree of calcification that the valve has gone through and also tells us about the area of damage of the valve. And we also get to know an idea about the valves. In addition to the valves, we also get to know about the coronary arteries. So whether there are any blockages in the coronary arteries is something that we would understand by doing a CT coronary angiography or a CT aortogram. So when we have a patient who presents with aortic stenosis, we usually classify them into mild or something known as a disease that's not really progressed to a severe stage, or the patient could be what we call as a severe aortic stenosis, where the valve has become so much damaged that we need to do something beyond medicines. So in patients who have mild aortic stenosis, well, medical therapy is something that is preferred, and most patients would be put on medications which include statins or cholesterol lowering pills. They may be on blood thinners, and they would sometimes be on urine pills, which would get the blood or the urine out of the body so that the patients feel much better in terms of breathlessness. For patients who have advanced heart disease or advanced aortic stenosis, well, these patients probably do not do well with medications alone. Or if your ejection fraction is low, if your heart pumping is weak, then again medications is not what you would stick to, and one needs to act on these patients to make sure that the valve is changed or the valve is replaced. Now, in case of replacement, all these years we had only one modality, and that was what we called as SAVR or surgical aortic valve replacement, where the patients had to go through a surgery and the surgeon used to make either a midline incision or an incision at the side and put in another valve, which is known as a bioprosthetic valve or a stainless steel valve, to make sure that you could replace the damaged valve and put in a new valve. So this was the only therapy that was available for many years. But eventually we realized that there were a lot of patients who, because of the age, because of their thin body structure, or because of associated diseases such as a lung disease or a kidney disease, were probably not good candidates for surgery, or those who had a high surgical risks, and therefore these patients were being denied the benefit of surgery. So these patients did not really have another option other than to be committed to a life of great sort of difficulty with their symptoms despite being on medications, even though they needed something to be done. And therefore we now have an option which is known as a TAVR, which is trans-aortic valve replacement, where rather than doing a surgical replacement of the valve, we through the groin put in a special valve without the need for any open cuts into the chest, and this valve is put through a groin approach similar to an angioplasty that is done, and the valve is implanted into the aortic valve, and it acts as another new valve for the patient. And over a period of many years now, and we have data for almost more than 5+ years to suggest that this approach is also equally good as compared to a surgical aortic valve replacement in patients who are high surgical risks.
So treatment of choice for aortic stenosis varies with the age of the patient, type of the disease. So essentially we have a way called aortic valve replacement by surgical method. We open the chest, we take out the diseased valve and put the new valve. This is called surgical valve replacement. But nowadays TAVR is being favored more because it is less invasive. Patient can be discharged in 24 to 48 hours time.
If you see the aortic stenosis of severity, who are symptomatic aortic stenosis, there the treatment is very, very essential. In younger population, those who are less than 20 years, we just do a plain balloon valvotomy in pediatric group and let the aorta grow, let the valve grow, and when they re-stenose, then we give the definitive treatment. So we need to give a lifetime management to these patients. So those patients who are elderly, there we can, who are at a high surgical risk for open heart surgery and prosthetic valve, there we treat them by TAVI procedure, which is percutaneous aortic valve implantation. But we should always look not only to feasibility, because now we are going in the realm of low risk group also, where we need to see that what all in future the patient will have, and if they survive beyond the valve life, then how it will be managed. So we can treat them by balloon, we call it BAV. It can be treated by open heart surgery and aortic valve or surgical aortic valve replacement, and then it can be treated by percutaneous technique, which is called TAVI or TAVR method.
All type of valves can be used in almost all patients, barring a few situations. If someone has a kind of a very high calcium burden, and then we require a very kind of a robust valve which can have a good mechanical strength. Patients with less than 21 millimeter aortic annulus, we should be going for a self-expanding valve. Rest in all situations, probably both balloon expandable and self-expandable valves can be used.
And there are two types of valves that are available. There's what we call as a balloon expandable valve, where the valve is mounted on top of a balloon, and the balloon is expanded onto the aortic valve area to get the valve opposed to the annulus. And there's another approach which is known as a self-expandable, where rather than a balloon, the valve expands on its own into place when you have this sort of an area. So among the two, I think we are more comfortable with the balloon expandable valves, especially as we tackle more challenging patients. So my choice of a balloon expandable valve would be more when we have patients who have what we call as bicuspid aortic valve, where the valve is not really the tricuspid or the three cusps, when you have only a two leaflet cusps, where opening up the valve in a more elliptical fashion or in more circumferential fashion is important for you, and therefore that's an indication where we normally use a balloon expandable aortic valve. And the second are two areas, as one is where a coronary height, when you have a coronary artery which is very close to the aortic valve, then the risk of having an entrapment of the coronary arteries is much greater when you use a balloon expandable valve, or when you have conduction system disturbances, where there's a higher chance of having the need for a pacemaker post aortic valve replacement. I think these are the places where a balloon expandable valve rather than a self-expandable valve becomes a choice for us.
Indian patients are different from the Western population, because in Western population it's mostly a senile degeneration of the aortic valve, and valve is tricuspid. In Indian patients, even at the age of 65 or 70, we get almost 40 to 50% of aortic stenosis which are bicuspid valves. Now, bicuspid valves are a different subset to treat. Calcification at times are heavier, and it has to be planned little differently. So I think we have an edge over the Western counterparts, Western cardiologists, to plan a TAVI in a bicuspid valve, because we do so many bicuspid cases. So one, there are few things which need to be done separately or differently in bicuspid valve aortic stenosis while planning a TAVI. All bicuspid aortic valves should be pre-dilated before a TAVR implantation. Placement of a TAVI valve should be a bit shallow in bicuspids. And then we have to be very particular about the coronary protection or security of the coronary arteries also. So as far as the valve selection is concerned, we are pretty comfortable with balloon mounted valves, which are again available in India. And at times we can think of a self-expanding valve also. So I would say it's a pick and choose depending on the various parameters of that patient.
So if you see, by definition, bicuspid aortic valve would present much more younger age group, because of the wear and tear it happens at a younger age group. So once we have gone in the low risk group and medium intermediate risk group of patients. So our Indian patients, unlike the Western data, we see more often more than 60% of them would be bicuspid valve. So in this situation, and those who we do TAVR, there we see even more cases who come for bicuspid anatomy to the tune of 70% would be there, and they are more or less in the age group of 60 to 70 years. So you can imagine that these are the patients where the lifetime management is very, very important. And in that case, we don't want any compromise in coronaries, because if you look at the data, the adverse outcome is much higher if the coronary compromise is there. The future ease of access to the coronary is very important. So for that reason, we try to use this valve, which is balloon expandable in younger population, as the first therapy. And as we discussed previously, that if you have to do TAV in TAV or future coronary access, so in this, if after 10, 15 years, whenever the valve restenosis, we can go for a supra, annular, like self-expanding valve. So you give a lifetime management to these patients. If you choose first valve as a self-expanding, then you are doing disservice to these younger patients, because then putting a balloon expandable within the self-expanding is not a good thing to have. And second, these patients are, remember, younger, so the coronary access will be also in question.
So this is called a lifetime management of aortic stenosis patients. So if we use a prosthetic aortic valve, which is bioprosthetic valve, which is a TAVR or a surgical aortic valve. So we are talking about TAVR, so let it be on TAVR. So we put a first TAVR valve, and in 8 to 10 years time, we expect, if the patient stays alive, which is most probability he will be, we can be having a need of second valve for this patient. And when we put a self-expanding valve in this situation, the patient can have in future again a coronary problem, and you go for a TAV in TAV, then also it becomes a little difficult, because there is a huge cage which is there. So considering this TAV in TAV, always the balloon expandable valves gives you an edge. So all patients less than 75 years, if you feel you're going between 65 to 75 years, then maybe in my approach, a balloon expandable valve is a better choice, because the next valve could be else. But in between, if the patient develops coronary problem or it requires a TAV in TAV, this will be a better option for the patient.